Hello, this is Michael Matson. I'm completing my case connection video. The first case that I would like to review is case 3 of the 5-year-old boy who presented to the pediatrician's office with intermittent drowsiness with frequent urination and persistent thirst. He is demonstrating symptoms of type 1 diabetes, and this was confirmed by the insulin testing after the glucose load test in the office. Um, Type 1 diabetes is a condition where there is autoimmune destruction of the beta cells of the pancreas, and those beta cells are responsible for releasing insulin into our bodies when we have consumed carbohydrates. So when the insulin is normally secreted, glucose will be delivered to our liver and skeletal muscle, and it will be able to be used for glycolysis and eventually producing ATP with oxidative phosphorylation, and that's where we will develop, or get our energy. And so in children who lack insulin, they are not able to deliver the glucose to the cells and will often be lethargic or drowsy because they're not having any energy production. In particular, for this patient, his mother was complaining of the frequent urination. That's driven because the glucose load will get high enough in the serum that it will start dumping into the renal system, and the glucose molecule will have a pull effect or an osmotic effect on water, and so that will increase the amount of urination that a patient will experience by way of an osmotic diuresis. And that will result in hypovolemia, and that will stimulate the thirst response, which is why the patient was thirsty. Um, as far as other biochemical processes at work, um, really that's kind of the driving factor. This patient would be at high risk for one of the major complications, and sometimes the only presenting uh, manifestation is diabetic ketoacidosis. And as far as the glucose levels in this patient, he of course would have elevated glucose levels as the insulin is not present to deliver that glucose to the cells, and so it would remain in his serum. Um, and in his situation, he would have some unchecked enzyme activity. This is primarily due to elevated glucagon levels. The glucose levels in the blood are regulated by the insulin glucagon ratio. If insulin is low and glucagon elevates, then you will have processes such as gluconeogenesis and glycogenolysis that will uh, go unchecked essentially. And so the major enzymes that would be involved in that would be phosphofructokinase A, which is actually phosphorylated into phosphofructokinase 2, and um, that will primarily function in the gluconeogenesis pathway for taking fructose 2,6 bisphosphate and converting it to fructose 6 phosphate, which then can enter the glycolytic pathway, and that will contribute to more hyperglycemia. And also, you'll have glycogen phosphorylase, which really is only indirectly regulated by insulin, um, but that will also be active, and that is responsible for cleaving the glucose 1 phosphate from the glycogen and allowing that to then enter the glycolytic pathway as well. And so those two enzymes will be active as the insulin levels are not there to suppress their activity. Um, the second case that I looked at was case 4 of the 2-month-old female who was having what her mother called jittery spells after breastfeeding. And it really didn't show up until she started sleeping longer. And that really would be consistent with glycogen storage disease. Um, Glycogen not really being used until a person enters into a fasted state, which does take some hours after feeding. So if she was feeding frequently, then she wasn't uh, going to manifest with that disease until later on. So as far as kind of the overall commentary, glycogen storage disease is actually kind of an umbrella term where either in the synthesis or breakdown of glycogen, there is a lack of enzyme activity in patients. It can occur in different tissues, primarily in the liver and muscle tissue, although the kidneys are involved, heart can be involved. There's a lot of different classifications for that particular disease, and it will kind of present with the hypoglycemia because she's not getting the liver to produce glucose from other substrates as those enzymes are lacking. And so she can't undergo glycogenolysis to be able to have those available substrates to cover her until she has her next feeding time. Um, as far as her physical exam, she had a hepatomegaly, which is essentially a palpable liver. That really manifests from glycogen buildup in the liver. Um, and as far as the epinephrine administration, increasing blood lactate without increasing her blood glucose would be consistent with having GSD primarily in the liver, as her um, skeletal muscle could undergo glycogenolysis, which would result in the elevated blood glucose, but that does not contribute to maintaining a normal blood glucose level, period. So as far as the other conditions, hereditary fructose intolerance um, really it's a disease of deficiency of aldolase B, which we know cleaves fructose 1 phosphate to uh, dihydroacetone phosphate and glyceraldehyde phosphate, and those are intermediates in the glycolytic pathway, um, as well as the fructose pathway, and that really doesn't present until a person starts introducing other foods outside of just breast milk. Breast milk doesn't contain fructose. And so that really wouldn't manifest until later on, until she actually started consuming other foods. And then galactosemia, now that one could produce symptoms early on because galactose is in breast milk and lactose. Um, but that, so in this case, she was doing fine and then later on had symptoms where galactosemia typically will have early onset of symptoms. Patients are often having vomiting and diarrhea because they're not tolerating the metabolism of galactose. They will have a hepatomegaly, but they'll also present with jaundice as well. And then they won't feed very well, where this patient did feed well. And that develops from a lack of primarily, really, it's basically any of the enzymes in the galactose metabolic pathway, but primarily galactose 1 phosphate uridyl transferase, which takes galactose 1 phosphate converts it to UDP galactose, is the most common enzyme deficiency, and she simply is presenting with other symptoms and at a later time than what we would expect for a patient with galactosemia. And then for glucose 6 phosphate dehydrogenase, that actually is an interesting deficiency, but one primarily of the red blood cells. Um, and that really, so G6PD is used in production of NADPH. That's kind of a buffer system for the red blood cells. If a patient is lacking in NADPH via a deficiency of that enzyme, that person typically will manifest in times of oxidative stress. That's certain medications that we might give, certain foods that they might interact with, and that can present with jaundice as it's occurring in the liver and elevating the bilirubin levels, and primarily acute hemolytic anemia uh, is kind of most commonly associated with a G6PD issue. And so that's usually going to be later on in life, not typically going to be it can be in a younger patient for sure, but very inconsistent with this baby's presentation and other symptoms.